So, the aim of the trial: does laparoscopic surgery improve recovery when open surgery, traditional surgery, is optimized within a program that we know, that we might debate the title of it, but we know both reduces complications and hospital stay. So should be considered our default option in surgery today. My hypothesis was that laparoscopic surgery improves outcome even when open surgery is optimized within what I call an enhanced recovery program. I should have said before this that I don't have a slide for this. And can we actually go back to the first slide, please? I should also say that this is an enormously involved study, as any multi-center randomized trial is, and these people listed here on the trial management group and all have contributed enormously. CRUK have funded it. The Bobby Moore Foundation have found the money, although CRUK allocated funding. Oxford Clinical Trials Oncology Unit have run it, and the Centre for Statistics and Medicine have collaborated. I have two disclosures. One is I received research money from Ethicon for a salary of a trainee, and I received money from Olympus in the form of surgical research equipment. So, going to the study design. You can see it's a one-to-one randomization with the appropriate power to detect a difference in fatigue. That primary endpoint was chosen because CTAC, the committee allocating the money, felt that hospital stay was not an adequate outcome measure, didn't measure the global recovery after this sort of surgery. But the study was powered to detect a difference in hospital stay as well, with the numbers involved. Adult patients having elective surgery, you can see the trial was stratified by age, colon or rectal cancer site. So importantly, it's a trial of rectal cancer surgery as well, in the way that Professor Janes described the classic trial, involving many centers and 6 recruiting reasonable numbers, more than 10 patients. Primary outcome, I've said, was physical fatigue, although powered also to detect a difference in hospital stay. And the normal clinical outcomes you would expect, complications, reoperation, readmission, other quality of life, so-called quality of life indicators. One may debate that, whether they're quality of recovery indicators as well, and health economics and cost utility. And I won't touch on that today as the data is not available. And I should say this is slightly preliminary data. I hope it will be identical in the fullness of time, but the main messages will be identical. What about the study itself? One of the strengths was that these were experienced laparoscopic as well as open surgeons. In my view, there's no point in running this trial if you haven't got expert laparoscopic surgeons, because we should start with that group and see if there's a difference before we then assume we can roll it out to all surgeons. So we tried to pick people who are very experienced. We needed to blind patients and observers. There were 2 preceding trials like this when this was set up, both small, one blinded and one unblinded. And it's an important aspect in trial methodology to have the patients as well as the observers blinded to reduce bias. So we did that by applying a large dressing which was impermeable to blood. And patients, nurses, and other treating members of staff did not see the wounds. They were changed every 2 days by staff from another team, and the patients did not look. We used enhanced recovery program in both arms of the study, and we circulated 30 items within the program to all the centers before the study to gain agreement as to what was appropriate and acceptable. But the guiding aspect was that all elements would be used in both the laparoscopic and the open arms, whether you used 30 elements or 15 elements. And we had central pathology review as by Phil Quirk and Nick West in Leeds to look at quality. This is the Consort diagram, and there's two things I'd like to highlight. One is that you'll see exclusions of 645 patients, of which nearly 300 declined to participate. And I wouldn't advise anyone to do another laparoscopic versus open trial. It's really difficult. But we did manage it, and the only other thing to highlight is that about 10% of each group did not have their primary outcome assessed by fatigue because there were problems with some forms, either the baseline form or the 1-month follow-up form. But roughly 100 in each group after 2 exclusions in each arm. Now, blinding, you may be surprised to know that blinding is possible and was successful in virtually all patients, virtually 90% of patients. And what's more, patients can't tell what arm they're in. They could toss a coin and know as well. And the staff aren't much better. That may not surprise Professor McPhee, but it surprised some of us. The conversion rate in this trial was extremely low when you bear in mind that all the previous big multi-center trials were 19% plus, and even the LAFA trial recently reported 2 years ago from Holland was 11%. So the conversion rate is low, probably suggesting that these surgeons are experienced either at not converting patients or selecting patients who are suitable for laparoscopic surgery. And we measured 20 enhanced recovery interventions, and you can see there's a similar number of interventions, compliance with the intervention in each group, a compliance figure of 10 in each group. So we could discuss the quality of the enhanced recovery program in this trial because we've actually recorded every aspect of the enhanced recovery program. So we've recorded it partly to compare the arms and partly to be able to discuss it. None of this will surprise you. The age is a typical British age group. It's not on there at 70. We'll see that in a minute. A proportion of patients had preoperative radiotherapy, and some had metastatic disease. Most patients are overweight in the trial, as one would expect. Sorry, age is 70. A proportion of patients had a stoma created, largely because they're rectal cancer patients. Similar POSSUM scores, difference in the length of incision, 47-minute difference in the operative time, despite the fact these are relatively expert surgeons. And we allowed trainees to perform the operation, provided they were assisted by a consultant. So the consultant, the trial investigator in each hospital had to assist them, but we felt we couldn't run the trial if we didn't allow the trainees to do some of the surgery. I've divided the operations into right and left, but the right includes transverse colon, so a similar difference in colonic disposition of cancer. A relatively small number of patients having AP resection, roughly 20%, and similar distribution of the operations in each group. Compliance. You're not meant to read this, but the figures here just show you that there's a similar compliance with each enhanced recovery intervention between the lap and the open group. If I was just to take avoidance of drainage, the second bar along, roughly 90% compliance. So as I say, one of the strengths of the trial is we can measure the quality of the enhanced recovery care and compare it to future studies, which is something that hasn't been done before except in the LAFA trial in large trials. Median number of enhanced recovery interventions measured was 10 in each group. And what about the pathology? Essentially, there's no significant difference or trend to worse outcome in either group, certainly not on the laparoscopic side. So distance to high tie, similar. R0 resections on the top line, roughly 3% in the lap group and 6% in the open group. number of lymph nodes as a reasonable number. So reasonable quality metrics, whether it's for the totality of the pathology or subdivided into rectum or colon. And I won't labour it for time. And Duke's stage not significantly different between the different groups. When I show no tumour there, those patients had a polyp cancer and required a segmental colectomy or rectal resection, so they have a T1 cancer with no residual disease in the specimen. We independently vetted the quality of the surgery. This was done on specimen photographs in the way that's been described by Nick West and Phil Quirk. And mesocolic plane in the top left graph in the middle is quality A, best quality, where we should be. Intramesocolic is quality B. And you can see similar quality surgery in both colonic as well as rectal surgery. And the APR resections are similar, but they're small numbers. We've subdivided. We initially decided to analyse complications on the Lang classification published in the British Journal of Surgery. Then we subdivided it subsequently into Clavien-Dindo because I think it's a bit more useful. And there's no significant difference in the minor Clavien-Dindo complications, the major ones, category 3 to 5, or no complications. There's one death in the trial within 30 days. I may be wrong, maybe 2, but I think there's 1. If I use the Lang classification, which is a more difficult one to use, there's not a lot of difference between the different arms. And in particular, there was only one patient having an intraoperative complication who stayed more than 8 days, and I don't think the intraoperative complication was related to the long stay. So you might say there's a trend to reduction in postoperative complications, but these data are not significant. Readmissions and reoperations, a non-significant difference between the two groups. And what about the primary outcome? Unfortunately, from my point of view, there's no significant difference in the primary outcome with physical fatigue at all, no matter how we cut the data or reanalyze it. If we look at this slightly complicated chart, you'll see top left there's a significant difference in hospital stay between laparoscopic and open surgery, a 1-day difference. If you look at the total stay, as happens in most LATV open trials, the difference magnifies. It's a 2-day difference in stay, significant difference. And you can see those medians as a pale red line on the bottom graphs with the distribution of the dots being patients. You can see a trend, an increase in longer stay with the open patients on the right of each corresponding graph. If we look at it in a different way, this is medians and interquartile range, top left graph, primary stay. It doesn't matter whether it's rectum or colon. The rectum stayed 5 days for lap surgery, as well as the colons, and the open patients stayed 6 days. And if we look at the total stay, the open patients overall stayed 7, the colon open total stay is 6, and the rectal open total stay is 8. Now, so there's a significant difference in outcome with hospital stay. What have we got to compare that with in the literature? There is only one other multi-centre trial of LATV open within an enhanced recovery program. That's the LAFA trial. The data is identical. There are differences in the LAFA trial. They didn't include rectums. They didn't have a quality assessment of pathology. They weren't all experienced surgeons. It wasn't all cancer patients. And the patients weren't blinded. But essentially the data is the same. And what other references have we got? To put it in context, if we look at HES data from 2011, HES data for an open for colons, obviously we can't tell whether they're open or lap in the HES data. HES data for a colon is 7 days. So 7 versus 5, the quality of the surgery seems to be reasonable. The recovery quality seems to be reasonable. HES data for rectums is 9. If we just take the open rectum group, in this trial it's 6. So again, the quality of the surgery in comparison to the HES data would seem to be reasonable. And that's borne out by the quality of the specimens as well, analysed independently. These figures just show you the statistical significance of the data, which we've already seen. The subgroups don't quite reach significance. If we look at rectal cancer in context, the only 2 trials in the literature, and one good multi-centre trial, COLOR 2, published in March in Lancet this year. If you see their data, 8 days for lap and 9 days for open. So this data, this group of surgeons, seems to have done a pretty good job in terms of their surgery and perioperative care. If you judge outcome by median stay, which I think is a reasonable yardstick, although there are differences in different cultures, different healthcare economies, social differences. It's not a perfect measure, but it's some measure. If you look at the Korean trial, it's a trial in 3 centres with expert surgeons, published in 2010, I think, or 11, and really good results in terms of quality of surgery and conversion rates. They have an 8-day stay for their lap surgery and a 9-day stay for their open surgery. So this data, I think, is a credit to British surgery in terms of comparison with the world literature. And one of the things that I was so surprised about was the lack of difference. Although I've said there's a 2-day stay and total hospital stay, the lack of difference between lap and open surgery. And I was slightly disappointed. But you might say, well, open surgery, the patients and the staff can't tell the difference when the patients are blinded, and maybe open surgery is a very good option. And some people have said that for many years. But I would say it's only a good option when the team have a good enhanced recovery program and they can achieve a median stay of 6 days, or better, which some people clearly can. So there are many conclusions one can take from the trial. I would say that in conclusion, there is an improvement in outcome even when patients are blinded, even when patients are optimized within open surgery, but there are many aspects which I think are a credit to British surgery in the same way that David Jane described in the classic trial, and I hope will provide a foundation for future research. Thank you very much, Mr. Chairman.